Well, we have had an interesting discussion in the previous session, and I will put some more questions and debate in that. These are my disclosures. ABO incompatible transplant, as I said earlier, has established as an acceptable alternative method of kidney transplantation in India over the last 2 decades. However, there are some unanswered questions, and you have already seen some anti-ABO titers. That's what the debate was. Is there an initial titer which is not acceptable for transplantation? How high can you accept the initial titer? What is the final titer acceptable? 1 is to 16, 1 is to 32, 1 is to 64, 1 is to 128 also. Importance in causing ABMR. Are titers important in causing plasma versus immune adsorption? You already heard a talk on that, but uh, is one better than the other? I don't think there is an answer to that. Prevention of acute antibody mediated rejection. What is accommodation? What are the long term outcomes of ABO incompatible transplant? Are they as good as the ABO compatible transplant? And what are the other future perspectives? And I'll discuss one case also. Since Dr. Vinoy is unfortunately not able to, has not been able to come, so we will continue this for about an half hour. Is there an initial titer which is not acceptable for transplant? What is the final titer? Are titers important for? Antibodies form, as you know, within 3 to 6 months. They're stable by about 5 to 6 years. They decline as we grow older. These are cross-reactive antibodies formed against the antigens recognized as non-self, such as food, environmental antigens, bacterial infections, and others. And these are produced by bone marrow and lymph node glands. Three methods usually: tube, gel, and flow. You already heard about that. The problem is reproducibility of the same method in the same patient as well as across labs. And there may be IgG variation. Same sample tested in 29 centers, variation from 1 is to 16 to 1 is to 256. And IgM also 1 is to 8 to 1 is to 32. So there is a variation in the same patient across the labs as well as in the same center. Flow cytometry has a better reproducibility than gel, and gel is better than the tube, which has already been talked about. Initially, high titers were considered to be poor for long-term allograft survival. There are publications to that effect in early 2000s. High pre-op titers predicted antibody-mediated rejection. Rapid increase in the titer associated with antibody-mediated rejection and graft loss. And high titers at 1 to 2 weeks post-transplant, higher the chances of. These were earlier presentations, as you can see, somewhere around 2000s, and so that is what was considered at that point of time to be so. Clinical significance of isogluten. This is a paper in 2019, and you can see that they looked at titers more than 1 is to 1 is to 28 or less than 1 is to 128, and then rebound titers. Did they go up more than 1 is to 16 or less than 1 is to 16? So these were the titers, and when you look at all these groups, the rejection-free survival similar in all the groups. It didn't matter whether you had titers higher than, and the rebound titers were more than 1 is to 16 or not. And the graft survivals are also. So rejection-free survival and long-term graft survivals were similar. So the 2000, about 2005, 7, 9, it appeared probably that more publications started coming in later 2000s, that antibody titers may not be as important in the current tacrolimus, mycophenolate, and steroid era. And the acceptable immediate pre-transplant titers across most centers are somewhere between 1 is to 8 to 1 is to 32. In Japan, most centers do 1 is to 32 is acceptable. In some centers in Japan, 1 is to 64. Dr. Tanabe is here and he would testify that. And 1 is to 64 is acceptable. And I have seen papers where people have gone up to a post-plasmapheresis titer of 1 is to 128, or up to 128, they don't do any desensitization. So this seems that probably titers, at least over the last decade or so, seems to be less of an issue in comparison to what it was earlier. Now, is there a response to rituximab? Rituximab seems to be the drug which seems to have changed the ABO incompatible transplant. Prior to the rituximab, splenectomy was done, which was more morbid, and therefore that's no longer done now. And you can see that you have these anti-A, anti-B titers. These were significant. This is potential risk factors for antibody-mediated rejection after ABO incompatible transplant. And people who responded to rituximab, which was percentage reduction of CD19 cells, that was considered to be a response. And if you had a good percentage decrease in 3 to 5 days after rituximab, then that seemed to be those that in whom you had a reasonable response, they didn't have an antibody mediated rejection in comparison to those who had a good response. So that seemed to be one factor. And you can see that good response to ABO incompatible in comparison in antibody mediated rejection was higher in people who did not have good response. So this is cumulative incidence of antibody mediated rejection. The blue ones are poor response to antibody to rituximab. And this is graft and patient survival also, and you can see that those who had poor response in blue had a lower survival in comparison to those who had a good response. And this is from Dr. Tanabe's group also, and you can see that the incidence of acute antibody-mediated rejection was higher in those patients where the CD19 was higher than 1.2%. So those people who had a significant drop in the CD19 count to less than 1% had a better response to rituximab and did better as far as antibody-mediated rejection was concerned. Now, we've been talking about these antigens. Unfortunately, are the antigens which are important, especially for causing acute antibody-mediated rejections, are antigens which are there on the endothelial cells. Are they the same as the RBC, which is what we measure by the titers? So this paper suggests that we probably may be measuring the unknown. What is more important is probably the antigen expression. And maybe the antigen expression also changes because of renal ischemia, reperfusion injury. There may be a greater antigen. And this is type 1 antigen and type 2 antigens. And you can see that at the endothelium, there may be a greater expression of type 2 antigens. And one also doesn't know whether after renal ischemia perfusion or endothelial damage, is there an over expression of type 2 antigens, which is what may lead to antibody mediated rejection. So this is something again being talked about. We don't know what brings about this change. There may be some alterations in accommodation also which might be bringing about this change. We done 262 transplants. The highest titer we took was 2 patients with 4096, 4 patients with 2056, and then 2 more patients with 1000, and then there are a significant number of patients with 512 and others which were there. ABO titer which we accepted was 1:16. We have done both cascade plasma exchange as well as used rituximab in all our patients. We done immune adsorption also if the titers are more than 512. Pre-transplant workup, we look at isoagglutinin titers. We do single antigen bead assay in all of our ABO incompatible transplants. Now, we were not doing it earlier, but we've started doing it now. All our ABO. The reason is that you must know that you don't have an anti-HLA antibody in many of these, because then you don't know whether the antibody-mediated rejection is because of anti-HLA, which may not have been picked up by a cross-match. So there may be a lower level that can also get overexpressed in the post-transplant period. So it's good to do this. Complement levels must be done. There may be the acute antibody-mediated rejection that occurs in the ABO incompatible transplant is a TMA. When you look at the histology, it is all TMA. And it seems that there may be a partial expression of complements which might be highly prevalent in the community as such. It's expected that about 20% of people may have partial complement deficiencies, which get expressed, overexpressed during endothelial damage. And this happens in pregnancy, this happens with triggers like infections sometimes, and this can happen in ABO incompatible transplant as well. Many centers in India are now accepting 1 is to 32 as the final titer. So, summary so far is that initial isogluten titers don't seem to determine outcomes. And our 6 kidneys, which we had to remove, had titers, initial titers of 1 is to 64 to 1 is to 128. The higher ones did extremely well. And none of the patients had titers which went up in the post transplant period, and all of these graphs had titers which were lower actually. So I am not so sure at the time of antibody mediated rejection if titers are important. Desensitization procedure to lower pre-transplant isoglutamine titers to about 1 is to 16 or 1 is to 32 seems to be acceptable in most. We accept 1 is to 16 at the moment at our center. Some centers accept in Japan 1 is to 64. Quantifying probably CD19, which we have started doing now, 3 to 5 days after rituximab injection might provide a method to prevent. If you don't have, maybe give another dose of rituximab at that point of time. And single antigen bead assay by Luminex to assess pre-transplant or anti-HLA antibody should be done in all ABO incompatible transplant. Plasmapheresis versus immunoadsorption, no randomized trial. Meta-analysis comparing similar results. And for titers up to about 1 is to 256 is probably cost effective to do plasmapheresis, but if titers are higher than this, probably immune adsorption may be more cost effective. This is the meta-analysis which shows whether you have on, this is not randomized trial, this is again whether of plasmapheresis or immune adsorption, the incidence of overall outcomes, antibody-mediated rejection are very, very similar. And this is the paper I was talking about. This is from Dr. Kutte, about 1,750 patients, a national cohort of patients, not again randomized. And you can see that immune adsorption probably carried slightly higher incidence of a biopsy-proven acute rejection. It may not suggest much, but one needs to be sure that you are not unnecessarily preferring one over the other. Overall, the outcomes seem to be similar with either of these. How can you prevent antibody-mediated rejection? This is what you see when you get an acute antibody-mediated rejection. This is diffuse cortical necrosis that might follow very quickly. And as I said that, does induction matter? Is it ABO anti-IL-2 receptor antibody in the upper one, ABO incompatible transplant with polyclonal antibodies, and ABO compatible with interleukin 2 antibody. The upper two ones are with IL-2 with ABO incompatible and ABO compatible and ABO incompatible. It seems that probably we also use IL-2 receptor antibody induction with ABO incompatible transplant. And the reason we do it is that we give also rituximab to these patients. If you give thymoglobulin to these patients, unless there is a specific reason to use thymoglobulin because of a HLA incompatibility or HLA mismatches, and then otherwise, or some form of sensitization. Otherwise, we usually use IL-2 receptor, and the outcomes as shown in this study are also very good. And you probably don't overkill and cause more infections. And this is rejections after. And what mattered probably in this was the response to the CD19, and this is what I had shown you earlier as well. So antibodies seem to have a poor correlation or positive predictive value of higher titers is also poor. Immunoadsorption and plasmapheresis, similar. I don't think there's any difference. Induction agents, I feel personally that IL-2 receptor antagonists may be better in combination with rituximab in these patients and may not cause more infections and ATG. But the studies also don't suggest that IL-2 and ATG are any, as far as outcomes are concerned. Most of the AMRs are histologically and clinically TMA, and complement regulation may be defective in these patients. And I feel that some of these patients probably, the question is how do we identify these patients is still not out. We had 7 patients who had, out of the 262 who developed antibody-mediated rejections, all 7 patients AMR within 24 to 7 days, graft nephrectomy in 6. Blood group antibody titers at the time of was 1 is to 16 or less. DSAs were done in 5 of the 7 patients, and they were negative in these patients. So they didn't have, at the time of we had done anti-HLA antibodies in them. So there isn't any correlation, acceptable titers in various centers across, as I said. Now let's talk about some accommodation. Three expected responses post-transplant. Antibodies might go up and they might induce allograft rejection. Immunological tolerance to ABO antigen, no antibodies are formed and no rejection occurs. Accommodation when antibodies go up but don't cause rejection. That is accommodation. So the antibodies are coming back, and if you do a biopsy in ABO incompatible transplant, you will find C4D positive in all of these patients. So don't look at C4D positivity as a sign for antibody-mediated rejection in these. Now, criteria for accommodation is that you have an anti-ABO antibody in the recipient serum, normal graft histology, presence of A and B antigen in the graft, renal function similar to ABO compatible transplant. So structurally and functionally normal graft in the presence of C4D positive in the blood vessels and in the kidneys, and higher titers of ABO. Unfortunately, the mechanism of accommodation is unclear. There may be probably a change in the function of anti-donor antibody. The antibody itself might change. Changes in the antigen might occur. Acquired graft resistance through anti-apoptotic genes get overexpressed and they might cause accommodation. Expression of complement regulatory proteins such as CD59 looks to be a reasonable kind of a reason why accommodation. So this complement regulatory protein may not be effective in some of these patients who have complement deficiencies or genetic modifications, and they're carrying on, but they need a trigger, and trigger can be an ABO incompatible transplant and renal ischemia perfusion injury. Shift from IgG1 to IgG2 isotypes does occur, and this may be again leading to some complement. And there is some evidence suggesting that actually there may be a switch from IgM was being talked about, and this thymus independent antigen may cause switch from B1 cells, and this looks like mediated by the IgM. CD5 B1 cells, if they switch to CD5 B2 cells, then they express and have a high affinity for the antibody, and then they're T cell dependent and they may cause antibody mediated rejection. So switch from CD5B1 cells to CD5B2 cells, which express more. And this switch may be mediated by IgM. So this is one, but still not clearly explaining why accommodation doesn't occur in some of these patients. Majority of patients will accommodate within 2 to 3 weeks time, and they usually carry on, and the long-term outcomes of these patients will be similar to ABO compatible transplant overall. Infections, graft loss, and patient survival are important. And this is the first paper from Montgomery, which looked at, this is all US patients, and this was in 2012. You can see that there is, if you look at the graft loss, in the initial month itself, you have a decreased graft survival in the ABO incompatible transplant, and that's because of that antibody-mediated rejection. In the earlier papers this is from from Japan, and you can see that 1989 to 2004, you had that dip, and the survivals were poor. But in the 2005 to 2013, you can see that the outcomes, that dip is disappeared, and they may be able to salvage these patients who develop acute antibody-mediated rejections later. And if you look at the outcomes, patient survival is extremely good. So you should not lose an ABO incompatible transplant patient. You might lose the graft, but keep the patient surviving. I think that's important. Take out these kidneys earlier. Don't let these, because they get into severe hemodynamic instability if you continue to keep these kidneys. And that's why this is earlier. Intervening earlier in these kidneys is extremely important. Otherwise, you'll lose the patient. And this is patients with ABO incompatible transplant. This is one meta-analysis which looks at that they have a higher risk of antibody-mediated rejection compared to center-matched ABO compatible. So the ABO incompatible patients will have a higher risk of antibody-mediated rejection. This is the meta-analysis, and this is not center-related, as was talked by Jitendra. It is related predominantly and kind of an unknown kind of a thing, as to it might occur all of a sudden in some of these patients. And crude and adjusted hazard ratios and confidence intervals for live donor ABO compatible transplantation survival, all-cause graft, and death-censored graft survival. And you can see that patient survival and all-cause graft survival, as well as death-censored graft failures, are higher in patients with ABO incompatible transplants in comparison. The hazard ratios are higher. And this is, again, you have patients with ABO incompatible transplants, inferior 1 year uncensored graft survival across centers, whether you use plasmapheresis or you use immune adsorption in these patients. And this is, again, Dr. Kute's paper I showed you. The survivals were very good in this cohort of patients also, and immune adsorption seems to be done. Overall, thymoglobulin was associated with slightly higher infections in these patients. What are the future perspectives? It's possible that we might be able to sort of look at accommodation and why. Modification of antigen expression, including endothelial. So as I said that probably it is the endothelium which is more important, and we might have to pay more attention to endothelium. And probably can we create a chimerism in that and reduce the expression of blood group antigens in the kidney by recombinant endo-beta galactosidase, which is produced by E. coli and BL21, and you can create a chimerism in these, and the expression of these antigens at the endothelium might change. Changes in the antigraft antibody functionally using a monoclonal. You have an antibody against the antibody, anti-A or anti-B antibody, Fab fragments, and this is can be done, and this might change the epitope expressions as well. Use of complement pathway inhibitor, eculizumab, has been done, and I'll show you one case which we saw salvaged recently. And whether we have a better method of measuring antibody titers, if they mean something. So maybe a flow cytometric method, but we need, as was discussed, we need these methods to be established, because we have used gel or tube techniques so far as ABO incompatible transplants so far have across the world. So using a new method, we'll have to establish a correlate between the gel method and this method, and this will have to be done at the individual lab level and maybe across the labs as such also. Eculizumab for prevention of antibody-mediated rejection, and you can see that titers in the post-operative period varied, but all these kidneys did extremely well with eculizumab. This was for preventing in high-risk patients. And we have had two patients. There was a young lady who, after pregnancy, developed acute cortical necrosis, and we found the CFHR3 gene mutation, deletion. And then now she was to go for a transplant again. Now we know that there is high degree of polymorphism, and these may be present in the general population in high degrees, but she has lost her kidney with acute atypical hemolytic uremic syndrome, TMA, on cortical necrosis. Now, transplant is going to be a high risk factor for this patient. Renal ischemia, and she can re-express similar kind of, and one kidney might be lost. And we have had one patient of that without using eculizumab in that patient. The transplanted kidney also got infarcted, and acute cortical necrosis occurred in that patient. But this lady, we gave eculizumab 4 doses, 1 dose prior to transplant and 1 weekly doses 3 weeks post-transplant. We kept the 5th dose with us in case in future something happens. She is now 2 years post-transplantation, done extremely well. So we haven't had. There was another patient who had aplastic anemia in childhood, had got an allogenic transplant at CMC Vellore. Then he developed atypical HUS and lost his kidney function, and we found that he also had CFHR. His mother was being investigated. She also had CFHR heterogenic mutation. So mother was not taken. She went for an unrelated transplant. This transplant also received eculizumab for 1 month during the transplantation, and he's about 7 years post-transplantation, done very well. So eculizumab can be used as a prevention in high-risk people who have had previous expression of some gene complementation. There is also a possibility of molecular deciphering of ABO incompatible ABO systems as such, and that might be helpful for both diagnostics as well as these patients. Eculizumab, as I said, no, sorry, this I showed you, molecular. So you look at the vascular endothelium, and they express ABH type 2 core chain. vascular endothelium at the site of inflammation. When you have this rejection or activation of the endothelium, then the expression might change actually from one type to another type. I told you type 2 antigen might, and the code 3 chain is expressed once the at the site of inflammation. Kidney expresses A and B group antigens, type 1 to 4 core chains, type 4 is the commonest. PCAM, plasma level, and these are all other factors which do cause inflammation at the time at the endothelium, and they may be again important, and we need to understand these expressions. So molecular might help us in uh, giving us more clues to this. Now let me go to this patient that we had recently. As I said, we have had, and this is a patient who had titers of less than 1 is to 16 to start with. So we didn't do plasmapheresis in them because that is the titer we accept as a final titer. And we've had 20 such patients out of the 262 where we didn't do any desensitization except give them rituximab, 200 milligram. That is the usual dose we use. And this is given 3 weeks prior to this. And we've had, as I said, 6 patients where we had to remove the kidneys, but this is the 7th one where we were lucky. He underwent an ABO incompatible transplant B2A with thymoglobulin induction because there was an HLA incompatibility. As I said, that we use IL-2 induction, but there was some minor degree. Flow cytometric cross match was negative. Pre-transplant desensitization uh, done with rituximab. Anti-B titers were 1 is to 16. The anti-HLA antibodies were somewhere around 1200, 1400 or so for one antigen. Immediate post-operative period, he had good urine output with good graft function, and serum creatinine reduced to 3.2 milligram of POD2. Evening of POD2, he developed severe thrombotic microangiopathy with decrease in urine output, hemolysis, hemoglobin dropped, and schistocytes in the peripheral smear, LDH went up, and haptoglobin was down. So there was full fly. So we stopped tacrolimus. We started plasmapheresis on him. But next day, also, he did not change. His hemoglobin continued to go down, and serum creatinine went up further. Plasmapheresis given, but hemolysis and thrombocytopenia continued. And we were contemplating now to do graft nephrectomy in them because he had started lowering his blood pressures now, and we were thinking that we might have to remove this kidney as well. However, we did suggest that eculizumab is a possibility that we can use in this patient. It took them a day to decide, and we were able to use it on POD4. The decision to give eculizumab in these patients is extremely. Time is of essence. Every second probably matters. The quicker you can do it, once TMA sets in, you will prevent acute cortical. Otherwise, you will have some sort of an acute cortical necrosis. And this is his hemolysis and thrombocyte. We gave him 1 dose on POD4, 900 milligrams IV infusion, and his hemolysis and thrombocytopenia stabilized by evening. His platelets was stable, and then over a period of next 3-4 days, he started improving his kidney function. And what we did, a biopsy was done on 8. I'll show you the biopsy also. 10 to 15% of the core showed an acute cortical necrosis, but his kidney function recovered. We gave him a second dose. We didn't have, actually, we couldn't get 900 milligrams. We could give him only 600 milligrams. And his creatinine now is 1.3 at this point of time. This is TMA, you can see the showing fibrin thrombi in the capillary loops, the meson trichome also showing you the same thing. And this is the 10% of the biopsy showed an acute cortical necrosis. However, this patient recovered, and he's now doing quite well, almost 2 months post-transplant, with a creatinine of 1.2. He has some degree of proteinuria related to thrombotic microangiopathy, which we are giving him angiotensin receptor blockers, and probably SGLT2 will be started maybe in few months. So, ladies and gentlemen, let me conclude. Although ABO incompatible transplant has established itself as a clinical practice, much of the practice still remains as an art than science. We don't have randomized controlled trials in ABO incompatible. So we need randomized controlled trials. So multicentric trials will have to be done because this is not a large number for a single center. We need better understanding of the importance of anti-ABO titers, their diagnosis, physiopathological importance, their biology, and probably accurate reproducible diagnostic tools. Mechanism of accommodation still poorly understood, and maybe molecular deciphering and expressions at the endothelium might change our understanding of the ABO system as well as the ABO incompatible transplant, and we might have a better control on what we are doing. Need randomized trials to establish the science of ABO incompatible transplant. So, thank you very much for patient hearing.